Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey, CardioNerds. This is Rick Ferraro, Cardiology Fellow at Johns Hopkins Hospital. Today, we are back for our second episode on the world of sodium glucose co-transporters. You've probably heard of SGLT2, but we might be talking about SGLT1 today, just to preview a little bit, and their impact on cardiovascular disease. I'm joined today, as always, by the tremendous series co-chair and director of the CardioNerds internship, Dr. Gurleen Kaur, a phenomenal internal medicine resident and incoming cardiology fellow at Brigham and Women's Hospital. Gurleen, how are you doing tonight?
Thanks so much, Rick. I'm really excited tonight to learn from this discussion about SGLT inhibitors. And I have the privilege of introducing Dr. Mariam Barkhordarian, an internal medicine resident at Hackensack Meridian Health in the great state of New Jersey, a current CardioNerds fellow and aspiring cardiologist. Her background from Yazd, Iran, the city which is famous for its sweets, drives her interest into diabetes and cardiovascular disease prevention. Great to see you here, Mariam.
Thanks for the nice introduction, Gurleen. I am so thrilled to be here today. I have the honor of introducing our expert faculty discussant, Dr. Muthiah Vaduganathan. Dr. Vaduganathan is a cardiologist at the Brigham and Women's Hospital in Boston, Massachusetts. He is a leading clinical trialist with over 250 publications and co-director of the Center for Cardiometabolic Implementation Science. He also hosts the podcast Don't Miss a Beat and Heart Failure in Focus, where he critically examines clinical care and research with experts globally. Dr. Vaduganathan, it is an honor to have you here with us. Welcome to CardioNerds.
Thank you so much. The honor is truly mine. I've been a fan and really a great admirer of the work and medical education that you all do and champion, and it's a real privilege to be able to join you today.
Dr. Vaduganathan, as we often do, let's get it started with a case from the CardioNerds clinic. Mrs. Cliff is a 57-year-old woman with a history of diabetes on empagliflozin with hemoglobin A1C of 6.3%. She is accompanied by her husband, Mr. Cliff, who has a history of heart failure with ejection fraction of 35% and was recently started on empagliflozin. During the conversation, Mrs. Cliff explains that she has been on empagliflozin for a few years for her diabetes, but now is unsure why her husband, who does not have a diabetes, would be on this as well. Dr. Vaduganathan, can you speak more to this evolution in the use of SGLT2 inhibitors from a medication exclusively for diabetes to now a key component of heart failure therapeutic management?
Thanks so much, Mariam. The hidden secret in cardiology is that most therapies that were developed for a particular purpose actually ended up being indicated for a vastly different reason. And so too, the SGLT2 inhibitors had such a circuitous pathway to ultimately its current indications in the US and worldwide. This all started back in the 2000s when there was initial safety concerns about certain classes of antihyperglycemic therapies, to the point where the US FDA issued an industry-wide guidance requiring all new sponsors developing therapies for diabetes because of its high prevalence in the community to conduct dedicated cardiovascular outcomes trials to exclude excess cardiovascular risk. This led to perhaps one of the greatest growths in scientific evidence across any discipline, and we learned a tremendous amount about not only the cardiovascular effects, but also the effects on other organ systems, such as the kidney, and specifically in terms of various aspects of the heart. The SGLT2 inhibitors benefited greatly from this, and there were really 5 large-scale trials that were conducted specifically evaluating people with diabetes at high cardiovascular risk, and this led to the rest of the story quickly unfolding thereafter. The initial signals suggested that not only were these therapies quite safe, but in fact, they had profound effects in preventing cardiovascular events, specifically preventing heart failure. and in delaying kidney disease progression. Both of these issues are, of course, very, very important for people living with diabetes. And so this captured broad interests amongst the community. And thankfully, the sponsors that developed these therapies, in fact, rapidly chased those threads of information, those initial hints of and signals of benefit, and dedicated studies then were pursued, specifically evaluating people with chronic kidney disease and people with heart failure with and without diabetes. And the fascinating thing was we learned that while the story started in diabetes, it ended in us understanding that these therapies and the therapeutic benefits of this class extend well beyond diabetes and in fact reach to chronic kidney disease and heart failure as cornerstones of management of those conditions.
Dr. Vaduganathan, thank you so much for walking us through that historical perspective and the trial data leading to SGLT2 inhibitors becoming a medication outside of just a diabetes drug, but with a more broad indication for use. And I think it's just really remarkable to think back of how in this field we're really able to use data from these large scale trials and change clinical practice and really focus in on implementation of these therapeutics. And SGLT inhibitors, we know, have a role within the cardiovascular system through multiple mechanisms, including but not limited to volume regulation, cardiac remodeling, and other cellular effects, which are still under investigation. Do you mind elaborating for our listeners more on these possible mechanisms of SGLT inhibitors and how they work in affecting cardiovascular disease, especially how they work to improve heart failure?
Gurleen, you're asking yet another very challenging question. And in fact, this is probably the second great secret of cardiovascular therapeutics and drug development is that we often don't understand central mechanisms of how these therapies actually benefit people. While we have this almost rosy picture of how drugs are developed from the bench to the bedside, going through phases of development with specific targets in mind and almost precision based approaches in which we design and develop therapies. Often therapies have systemic effects that go well beyond intended. And those benefits might actually be principally involved in ultimately preventing disease progression. The SGLT2 inhibitors have varied effects. SGLT2 is predominantly expressed in the kidney, in the proximal tubule of the kidney. Over 90% of those transporters are located in the proximal tubule. And so it would be remiss for us to dismiss the kidney as a central mechanism of how these therapies benefit the system at large, including the cardiovascular system. SGLT2 is not expressed in the myocardium, and so the effects and benefits we see on cardiovascular status must be either a myriad of factors that are systemically acting, for instance, some effect on blood pressure, some effect on volume regulation, some effect on metabolism in improving glycemic control, and all these come together to improve cardiovascular status. Or it might be off target effects on the heart, and perhaps while it might not influence a direct receptor or transporter present in the myocardium, perhaps it has off target effects on other ion channels, other receptors in the myocardium. And then finally, is that the benefits are truly outside of the heart and the heart is benefiting secondarily. And that is one of the notions that perhaps the kidney, really as a central actor, is improving cardiovascular status by improving kidney efficiency and in handling salt and water. All these mechanisms, I think, are certainly credible. I think mechanistic studies are very challenging to conduct because you can do a very well conducted study to prove or disprove one of these mechanisms, but it doesn't actually speak to the other mechanisms that could be at play. So my view is that we must recognize that these therapies ultimately in very well conducted large clinical trials do benefit people. And likely these benefits are systemic, that there are multiple mechanisms, much like the statins for atherosclerotic cardiovascular disease. We're now seeing that the SGLT2 inhibitors have a myriad of effects in improving cardio-kidney metabolic health.
Yeah, thank you so much for that discussion. It's really kind of the pleiotropic nature that you're talking about and what we're still learning about these medications is really remarkable. And it's been, really, really a fun time. I remember this was kind of in the early days when I started training, and it's really proliferated so tremendously. And so following that has been really a privilege. And so to get us back to the CardioNerds clinic, following your appointment with Mrs. Glyph, she sends a secure message via electronic medical record asking about her sister, Mrs. Flozen, who is also on empagliflozin for symptomatic heart failure, but has an EF of 55% as opposed to 35%. Can you elucidate more on the data and key trials in support of the impact of this class of medications in the management of patients with preserved EF?
It's a great question, Rick. As you know, and it has been discussed on this forum, heart failure with preserved ejection fraction has been a challenging entity to study. In many cases, has been described as the graveyard of cardiovascular therapeutics, and some have even gone to the point of describing it as the greatest unmet need across all of biomedicine. Thankfully, the SGLT2 inhibitors were the first therapeutic class to definitively show cardiovascular benefits in this high risk population of heart failure with preserved ejection fraction. The two principal trials were large scale trials of SGLT2 inhibitors in the Emperor Preserve trial. This was with the SGLT2 inhibitor empagliflozin, and then the Deliver randomized clinical trial studying the SGLT2 inhibitor dapagliflozin. These were similarly designed trials, globally conducted across many, many countries, involving many, many investigators worldwide, but were simply designed comparing the SGLT2 inhibitor against placebo in this target population of heart failure with mildly reduced or preserved ejection fraction, defined as an EF above 40% with elevated natriuretic peptides and evidence of structural heart disease. Now, these therapies showed benefits on improving cardiovascular death or heart failure events, and the effect sizes were substantial and clinically relevant. And their benefits were driven by both of those components. There was some benefit seen for even cardiovascular death and a predominant effect on preventing hospitalizations for heart failure and urgent heart failure visits. This led rapidly to labeling updates that these therapies now are not only indicated for people with heart failure with reduced EF, but for the heart failure syndrome as a whole, and actually simplified medicine in many ways. Often we're challenged by defining ejection fraction early because in certain regions of the world, there might be limitations in obtaining timely echocardiography or other modalities to define ejection fraction. This set up a system of medicine that simplified things, that moved away from ejection fraction, at least for this therapy, that allowed us to say this therapy was beneficial across the spectrum of ejection fraction and may even be initiated before you know the specific ejection fraction of that individual. This also is rapidly adopted by clinical practice guidelines and formed the first class 1 recommendation for a specific therapeutic in heart failure with preserved ejection fraction in the most recent 2023 ESC clinical practice guidelines for heart failure. So a really, really exciting space, and I think is just the first of therapies to show benefit. I think it paved a path not only to how we can study these therapies, but also perhaps of the types of therapies that might be beneficial in heart failure with preserved ejection fraction. Heart failure preserved EF often occurs in the background of cardio kidney metabolic conditions. And so perhaps these similarly systemically acting therapies, for instance, the GLP-1 receptor agonist or the mineralocorticoid receptor antagonist, maybe those are the same therapies that could actually benefit this target population of heart failure with preserved EF. So a lot more to learn about the syndrome, but exciting that this was the first breakthrough to have a definitive body of evidence to support a class 1 recommendation in clinical practice guidelines. So really exciting time in cardiovascular medicine, especially for heart failure with preserved ejection fraction. In my view, it not only taught us about how we can study these therapies, that we need to conduct really broad, large scale trials to be able to detect important effect sizes in this heterogeneous population, but also about the types of therapies that might be beneficial in heart failure with preserved EF. HFpEF often occurs in the background of multiple cardio-kidney metabolic conditions, so perhaps it's therapies that in fact act systemically, targeting each of these axes, that may ultimately prove to be beneficial, just like the SGLT2 inhibitors.
Dr. Vaduganathan, thanks for the nice summary of trials. It was really interesting to hear about simplifying medicine. I never thought of it this way, that we can use SGLT2 inhibitors without specifically defining heart failure with reduced ejection fraction or with preserved ejection fraction as a whole heart failure syndrome. Moving slightly away from cardiology specifically, but to a patient population we also see very frequently, I was hoping to ask about SGLT2 inhibitor use in patients with a renal insufficiency. Is there any role in the management and prevention of CKD?
Thanks so much, Miriam. I want to quickly touch on that comment you made about simplification. And I recognize as a community, we often have this balancing act between precision medicine, identifying patients that may likely benefit the most from a given therapy, and simplification, ability to actually implement therapies at scale. And I think in cardiovascular medicine, we take care of such a broad, high risk population that at the present time, we are more so in this broad implementation approach where we're identifying phenotypes that are recognizable by all clinicians, whether they be cardiologists or primary care doctors or nephrologists or endocrinologists. And we're able to treat that cohort of people in multiple different settings, in multiple different countries. We may actually move towards a very precise approach to care for some of the other phenotypes that we less commonly see. But I think in terms of garden variety heart failure with preserved EF or heart failure in general, I think this simplified approach to implementation may actually improve our therapeutic uptake and may improve our familiarity with these therapies and our comfort with these therapies. And perhaps, regardless of our specialty or our training, we may feel comfortable in using a common set of tools to combat disease progression in heart failure. Shifting now to chronic kidney disease, CKD has a tremendous burden in the community, affects about 40 million Americans, and has a tremendous footprint globally. CKD is a syndrome that has been challenging to study because it slowly progresses, and often clinically significant events such as end-stage kidney disease requiring dialysis or transplantation is a relatively infrequent event during the typical time course of a study. The disease progression is often asymptomatic, and so many individuals may be undetected or undiagnosed in the community. And finally, our tools that are available to actually diagnose CKD, such as urine albumin creatinine ratio, are vastly underutilized. And so this all coalesces and conspires to create a scenario in which we vastly underdiagnose CKD in the community and we understudy this population. The renin-angiotensin system inhibitors, ACE inhibitors, and ARBs have been the cornerstone of management for over 2 to 3 decades. And until very recently, we haven't had great breakthroughs in the care of CKD. The SGLT2 inhibitors were the first such add-on therapy to background renin-angiotensin system inhibition and have been studied in 4 separate randomized clinical trials, that is, Credence, DAPA-CKD, EMPA-Kidney, and SCORED. These 4 trials tested each individual therapies, SGLT2 and SGLT1/2 inhibitors, in this target population of chronic kidney disease. 2 of the randomized clinical trials, Credence and SCORED, specifically studied people with chronic kidney disease and concomitant type 2 diabetes. Most of these patients were thought to have diabetic nephropathy. The other two trials enrolled broader populations, including DAPA-CKD and EMPA-Kidney, studied populations with and without diabetes, inclusive of etiologies of chronic kidney disease unrelated to diabetic nephropathy, including specific glomerular nephritis and other etiologies of CKD progression. All four trials showed that these therapies modified disease course in chronic kidney disease. So they showed that you were able to actually reduce clinically relevant events such as dialysis and transplantation, even over a finite duration of time. You were able to bend the trajectory of kidney disease progression by slowing the decline of GFR in these patient populations. And most importantly, these benefits were seen irrespective of diabetes status, irrespective of etiology, and irrespective of the individual patient profile, for instance, if they were high or low risk. And so now SGLT2 inhibitors form another cornerstone of management of chronic kidney disease. And all these patients were well treated with background renin-angiotensin system inhibitors. And just like we've seen in the care of heart failure, we are now seeing in the care of chronic kidney disease that there are now multiple therapeutics that have been shown to delay disease progression in CKD. And so much like we consider GDMT of the heart in delaying disease progression in heart failure, there's now a very similar set of tools as a GDMT for the kidney to delay disease progression, ultimately reaching important clinical events like dialysis and transplantation.
Thank you, Dr. Vaduganathan, for going into more depth about the role of SGLT inhibitors in chronic kidney disease. That was just really a true masterclass of the trials in this patient population. And I really love that point you made earlier about how we're going from broad implementation and recognizing those broader phenotypes and moving more towards precision medicine. And I think all this discussion with CKD really speaks to the fact that SGLT inhibitors aren't a drug owned by one specialty only. It's really an intersection of cardiology, nephrology, endocrinology, and primary care. And this multidisciplinary collaboration is needed for effective implementation of the drug class and to get it to the patients that would benefit from it. And so far, we've been talking a lot about SGLT2 inhibitors, but we know there are medications that are both SGLT2 and SGLT1 dual inhibitors. Could you tell us a little bit more about the trial data of those dual inhibitors and their effectiveness across the heart failure spectrum and other indications for their use?
Yeah, thanks so much, Gorleen. And really, all six SGLT2 inhibitors and SGLT1/2 inhibitors that are now FDA approved have varying affinity to either the SGLT1 transporter or the SGLT2 transporter. And so, if given in equal potent doses, often will bind to both of these transporters. We often call most of these therapies SGLT2 inhibitors because they're mostly specific to the SGLT2 transporter, predominantly located in the proximal tubule of the kidney. Now, SGLT1 is also expressed in the human system, and that's predominantly in the brush border of the gut and has a very similar role in the reclamation of filtered glucose and sodium. And so these transporters both act in unison to control glucose homeostasis in the system. And so its inhibition of SGLT1 and 2 may lead to losses not only in the kidney of glucose that's filtered, but also of glucose in the gut lumen. So SGLT1/2 inhibitors that have more balanced effects on SGLT1 and 2 have also been developed, and sotagliflozin is the currently FDA approved SGLT1/2 combined inhibitor. This was a therapy that was studied in two randomized clinical trials that were in phase 3, SCORED and SOLOIST heart failure. SCORED was a very large trial of 10,000 individuals with chronic kidney disease and type 2 diabetes. SOLOIST worsening heart failure was a very unique trial of patients with worsening heart failure. These are patients who are randomized either just before or just after hospitalization for heart failure, and so studied the role of these therapeutics in the acute phase of illness in heart failure. So, unfortunately, during the conduct of these randomized clinical trials, the primary sponsor pulled funding from SCORED and SOLOIST, such that we had curtailed follow up in the case of SCORED, which was fully enrolled in over 10,000 individuals, but had short duration follow up, which impacted the actual ultimate study conclusions because this was ultimately a CKD progression trial, and CKD progression trials require longer duration follow up to accrue sufficient rare events like dialysis. And similarly, in soloist worsening heart failure, the loss of funding restricted the number of patients actually enrolled, and that was limited now to just over 1,000 participants. The clinical trialists were quite adept and quite smart about this and rapidly modified the primary outcome of these trials, recognizing that in one trial there was limited follow-up, in the other there was a limited enrollment, to really a broad-based endpoint of total cardiovascular deaths, hospitalizations for heart failure, or urgent heart failure visits. And in fact, in both randomized clinical trials, actually showed that this therapy, when studied in CKD, when studied in worsening heart failure, was able to modify that outcome of composite cardiovascular death and heart failure events. And that was counting both first and recurrent events. This actually led the FDA to provide sotagliflozin with a specific label of prevention of heart failure events in individuals with chronic kidney disease and in people with worsening heart failure. So really provided a clear pathway of how we can think about using this therapy.
Thank you for that comprehensive review and the mechanism and the trial data. I think all of our discussion tonight has really shown that there's a growing base of data supporting the implementation of SGLT inhibitors. And Dr. Vaduganathan, you've been such an expert in this field, so would love to hear your perspective of what do you think is the future advances in SGLT inhibitors for patient management. We know that we recently had another SGLT trial presented at ACC, the IMPACT MI. So I'd also love to hear your thoughts about that trial and what groups of patients do you think might benefit from SGLT inhibitors that we haven't studied yet? Where is the field headed?
Until now, we've talked about cardioprotection in people with type 2 diabetes, primary treatment of people with heart failure, irrespective of their ejection fraction, primary treatment of people with chronic kidney disease of various etiologies. And the most recent aspect and disease state that was studied was that after acute myocardial infarction. And that was studied in two randomized clinical trials, DAPA-MI and IMPACT-MI. And we may not have the time to actually dive into the details of these trials, but it essentially showed that mortality in this population was relatively low, in that most of these people after myocardial infarction in the contemporary era face relatively low mortality events because they're promptly revascularized and because standard of care is quite good, that our other therapeutics are excellent in preventing death. However, we also recognize that patients still face residual risk of other events, such as heart failure. And so the development of post-MI LV dysfunction and heart failure is still important, even in the current era of care. And so IMPACT-MI and DAPA-MI showed that you can actually prevent heart failure hospitalizations in people who suffered from an acute myocardial infarction, including those who were promptly revascularized, including those who were already well treated with other therapies that we know are helpful, such as statins, such as antiplatelet therapies, such as ACE inhibitors and mineralocorticoid receptor antagonists. And DAPA-MI was a little bit more of a unique trial in that it had to be adapted in terms of its primary outcome because it had a much lower target event rate. And so ultimately it was evolved into a win ratio type endpoint. And so the learnings from that trial were a bit more limited. IMPACT-MI was conducted a bit more traditionally, was a much larger trial, and was an event-driven trial. And so we learned that while these therapies can't bend mortality, which was one of the components of the primary endpoint, it does appear to prevent hospitalization for heart failure, which is a feature of this therapeutic class that we've seen not just after myocardial infarction, but across each of the disease states we just talked about: chronic kidney disease, heart failure, patients with established disease, as well as patients with diabetes who are at high cardiovascular risk. So we'll see how regulators and guidelines consider this data. But I think it's important to understand that this was a therapeutic area that we've made great strides in, and the SGLT2 inhibitors may have a role, at least in a selective population at very high risk for heart failure onset. There are many areas that I think are exciting ahead. We're now about 10 to 12 years after initial labeling of SGLT2 inhibitors. So many are reaching their patent expiration dates. And in fact, we now have generic therapeutic options in the United States. And so I don't think we can expect that principally industry sponsored trials are going to be the mainstay of what we're going to see moving forward. We're going to see federally funded studies. We're going to see more creatively funded studies moving ahead. The open-ended questions are, how can these therapies be effectively combined with other therapies? And so we now are seeing combination medical therapy trials, including polypills. There's a wonderful trial being led out of UT Southwestern. That's an NIH-sponsored trial of a combination polypill in heart failure with reduced EF. Furthermore, there are combinations with mineralocorticoid receptor antagonists that are being specifically studied in cardiovascular outcomes trials in heart failure. The other aspects are areas that were previously excluded. For instance, people with significantly advanced chronic kidney disease, including those already on dialysis. This is being now studied in large-scale trials, one of which is called Renal Life Cycle, which is about a 1,500 patient trial that's being conducted globally that's studying SGLT2 inhibition in people on dialysis, in people with significantly reduced GFR, and in people after kidney transplantation. There are some other areas that I think are of note. Until now, we've relatively discussed pretty high risk scenarios, people with not just type 2 diabetes, but those who already have maybe established cardiovascular disease or who are at very high risk for cardiovascular events. We've discussed patients with heart failure, chronic kidney disease, acute MI. But what about earlier on in the disease process, including people with just diagnosed type 2 diabetes? We should be learning from one such trial that is studying newly diagnosed type 2 diabetes and whether SGLT2 inhibitors should be first line care. And it's actually comparing that against metformin in a specific trial called SMARTEST that's being run out of Scandinavia. So that is another area of interest. And then finally, of course, is while as a field we've moved towards combination medical therapy, we also want to be parsimonious in terms of how we deliver care. And so the comparative effectiveness of these therapies, even against other mainstays of care, is also of high interest. And so PCORI has funded a large-scale trial called Precedent that is specifically studying SGLT2 inhibitors against GLP-1 receptor agonists in people with type 2 diabetes and established cardiovascular disease. This too will be an area to look forward to, because perhaps, at least in low, moderate risk individuals, maybe we should be starting with one class and then layering on the second if additional aspects of cardiovascular risk accrue in those individuals. So a lot to learn about this field. I think the core aspects of these fields have been well studied and rapidly so. It's remarkable that all this evidence has taken place over just about a decade. But I think we still have about another decade of learnings of how these therapies can be combined, how these therapies can be implemented in a timely basis, and how these therapies can be implemented in people who were previously excluded from those initial randomized clinical trials, including some that are very, very high risk for disease progression and clinical events.
Thank you so much for that incredible review. I'm looking forward to going back and listening to that again because there were a lot of takeaways from that. You had mentioned the polypill, and I'm really interested in that work, particularly with respect to GDMT. And obviously, I'm sure we've all had experience starting patients on heart failure, guideline-directed therapy, and they can go from zero to quite a few medications quickly. What sort of data is there for the polypill right now? What kind of progress do you think we're going to make in that direction?
Yeah, so I think this is really, really an important area because polypills have been shown to be beneficial in many areas across cardiometabolic medicine, including diabetes, in hypertension management, in other prevention settings. And we've now rapidly converged, and guidelines have strongly recommended multi drug regimens in the care of heart failure with reduced ejection fraction, especially, and even some people with mildly reduced EF. And so a polypill is a natural next step of what needs to be developed. I think until now, polypills have been challenging to develop in heart failure with reduced EF because there have been multiple sponsors of individual therapies that haven't actually had adjacent compounds in their armamentarium. And so developing a single therapy that encompasses all of them has been difficult. But now we're at a unique phase in which we're about 10 years after the development of the core therapies, including the SGLT2 inhibitors, including angiotensin receptor neprilysin inhibitors like sacubitril valsartan. And so we do have the potential now that generics are emerging that we can actually effectively combine them. So we're at a very early stage of development of polypills. I don't think that there yet been evidence of true polypills in heart failure. I mentioned that UT Southwestern trial that I personally am looking forward to. Individual companies are developing combination therapies, for instance, including two of the components, like an SGLT2 inhibitor and some modulator of the MR receptor. But I think a combination of four drugs, which we're often asked about, I think soon we'll see some attempts of. We'll have to understand how this will be taken up by the community because we are so used to having choice in cardiovascular medicine, choice of doses, choice of individual therapies within combinations. For instance, a particular beta blocker or a particular SGLT2 inhibitor preference, or even a particular ACE inhibitor, ARB or ARNI preference. And so that type of decision making needs to similarly be simplified when we're discussing polypills. And the appetite of simplification in the clinical community, I think, needs to be something that we'll need to wrestle with. So we'll soon see. It's a very early stage, even though these therapies have been around for a long period of time. We're now just at the point where we're about to see generics for all four core guideline directed medical therapy. And so it is truly a time point in which polypills for heart failure are in fact possible.
Thank you so much for that. That's really enlightening, but also enheartening. And I'm really excited to see what's up next for this because we've come such a long way, as you've highlighted via the data so far. But there's clearly a lot of excitement on the horizon as well. To wrap things up here, I'd love to ask your perspective on some of the key takeaways from our discussion on the data. It's been really a whirlwind tour here, and it's been really an incredible privilege to speak with you. But what are some kind of key points that you'd like to send to our audience?
Thanks, Rick. This is really a remarkable drug class that we've learned a lot about over the last decade. And SGLT2 inhibitors today are indicated across three specific disease areas: patients with type 2 diabetes, patients with chronic kidney disease, and patients with heart failure. In type 2 diabetes, they're indicated for their primary glucose lowering potential, at least in people who have preserved kidney function, because these therapies lose their glucose lowering potential at lower GFR as kidney disease progresses. And furthermore, it's indicated in people with diabetes for cardiovascular protection, prevention of cardiovascular events, including prevention of heart failure in individuals with diabetes. In chronic kidney disease, these therapies are now the first therapeutic class that have been added to renin-angiotensin system inhibitors in broad patient populations of chronic kidney disease, inclusive of people with and without diabetes. And finally, in heart failure, it's been shown that these therapies benefit patients across a broad spectrum of ejection fraction in preventing clinical events and preventing disease progression. These therapies have been studied in those after acute myocardial infarction who have either LV dysfunction or evidence of congestion, and the evidence is relatively mixed. There's some evidence that these therapies prevent heart failure onset after a myocardial infarction, but there's no specific labels for this disease area, and guideline bodies and regulators still are digesting the very, very hot off the press data from DAPA-MI and MPACT-MI. Broadly speaking, across these four therapeutic areas, this individual therapeutic class has been studied in 16 randomized clinical trials and has led to 6 different therapies being approved by the US FDA in short order. We now have the first generics available. And so we're hopeful that these therapies become more affordable, accessible, and equitable in terms of the implementation of them broadly. Despite their now 10 years of scientific investigation in really well-conducted clinical trials, there are many unanswered questions. And those clinical trials are actively being conducted, including in populations that were previously been excluded, such as end-stage kidney disease, including combination medical therapy clinical trials, and about trials specifically about implementation. Where, when, and how do we implement these therapies to allow for the best potential patient outcomes with their use? So I would say this is a paradigm of how therapies that were developed in one area may be quite successful in influencing broad patient populations. And it's a really, really exciting time for cardiovascular medicine because this has really reinvigorated not just cardiology, but kidney medicine, metabolic medicine, and has brought these fields really together in studying these therapeutics, even in multimorbid conditions. And on a personal note, I would say that this therapeutic class really started, and the very first of those 16 randomized clinical trials, EMPEREG outcome, reported when I was a first-year cardiology fellow. And at that point, I was relatively undifferentiated. I enjoyed cardiology, I enjoyed clinical trials, I enjoyed data science. But this was a trial that I recognized was outside of cardiology, but there was some magic to this therapeutic class. And so I invested a lot of my early years as a cardiology fellow in understanding more and trying to become more involved in growth of evidence around this therapeutic class. So my main advice is that use this as an example and keep your eyes open, because at whatever stage of training you're at, there are going to be surprises. And if history is going to repeat itself, cardiology is a therapeutic area of serendipity, and there will always be a windy road ahead. And we never know when the next great therapeutic is going to land. And keep your eyes open, because this is one of the most fascinating areas of medicine, because we have so much to learn about the cardiovascular system, and we learn it by pathways that may be quite distinct from what we're used to, from phase 1 to 2 to 3 to 4 investigation. And I would argue that most therapeutic advances in cardiology have taken a much less well-trodden path.
Thank you so much for distilling down the key takeaways of SGLT inhibitors. And it's just been so exciting to hear about the current ongoing trials and the future investigations in the field from you. There's truly a lot to look forward to for improving the care of our patients that we see every day in practice, and the road forward in improving implementation of these therapies. And we've really been able to hear your passion for the field in this discussion today, and great to see how you got involved in generating the evidence for these therapies. And it really makes me excited as I start cardiology fellowship and think about all there is to still discover and learn within the field and what therapeutic advances still lie in the future. For the last question for tonight, this is something we ask all of our guest experts on the show. We'd love to hear more about what makes your heart flutter about heart failure and cardiometabolic disease.
It's a great question, Gurleen. And to me, it is the wealth of data and evidence we have to guide care in cardio-kidney metabolism and specifically in heart failure. I think across disciplines of biomedicine, we have one of the strongest evidence bases in heart failure and one that we should be proud of. And in fact, many therapeutic areas can't say the same in terms of the survival advantages that our therapies can afford our patients. And so what excites me is the ability to actually influence a disease course of a patient population. And while we can't offer perhaps a cure to a person with heart failure, I think today, if implemented in a timely and appropriate manner, guideline-directed medical therapies have a full potential to completely change disease trajectory and be able to prevent or even delay clinical events to the point where most people can live very fulfilling lives ahead. And that is something that really, really generates a lot of excitement in me in contributing to this field and partnering with individuals just like yourselves in combating heart failure at large.
Thank you so much for sharing. I've really enjoyed every minute of this discussion and can't wait to listen back to catch all of the pearls that I may have missed. And we really went through a really thorough discussion of SGLT inhibitors and their clinical trial data. And I think I'm also looking forward to seeing how we can make these drugs affordable, accessible, and equitable, like you mentioned, and work on their implementation so we can change disease trajectory. And we're so grateful at CardioNerds to benefit from your wisdom. You've really been a pioneer and with all your prolific research in the field. So it's been such an honor to learn from your experience as a cardiologist and a clinical trialist in this area. So thank you so much for taking out the time to teach us all and to teach our audience tonight.
Thank you all. It's been a pleasure. It's been a great discussion. And most importantly, I want to share all our appreciation to what you do for medical education as a whole in cardiology. It has definitive impact, and I think it's really, really important.
Thank you so much.
Thanks for tuning into another CardioNerds episodes. The audio editing for this episode was performed by me, Muthiah Vaduganathan. I'm a CardioNerds Academy Fellow in House Taussig and the resident at Hackensack Meridian Health. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The view expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversation and exploration in our upcoming episodes. And now it's time to make like an S2 and a split.